Actually, my question is about the fertility treatment in PCOS. What is new in ESHRE 2023? Actually, I will discuss about my points. The first one is the preconception risk factors. As we know, the PCOS routine recommend should have a routine recommendation and specific considerations. The preconception modified on risk factors that can be modified is the BMI, smoking status, and the pre-existing medical conditions as diabetes and epilepsy. And we should pay attention that the lean women or normal weight women had a lot of birth rate more than the obese ones. So the optimization of smoking and BMI, diet and nutrition condition may improve the reproductive and pregnancy outcomes in PCOS patients. Number two, the tubal patents testing. There is no evidence to support that tubal disease is more frequent in women with PCOS. But when I am doing tubal patents tests, actually in specific situations, in the pelvic surgical procedures, previous abdominal surgeries, PID, and the concomitant endometriosis. After the preconception care recommendations and the tubal patents testing in individualized basis, we should go to the ovulation induction. It is all it should be considered the first line pharmacological treatment in PCOS patients. And there is no evidence to increase the teratogenicity comparing it to the natural conception or other ovulatory induction agents. The clonconcentrate and the metformin. Actually, the letrozole is off-label in some countries. So these countries can use the clonconcentrate and it could be used in preference to the metformin to increase or improve ovulation and the clinical pregnancy rate. Colon concentrate combined with metformin could be used rather than metformin alone or colon concentrate alone to improve the ovulation and the clinical pregnancy rate. The gonadotropin. Gonadotropin is actually used as a second line pharmacological therapy. The first line failed to induce ovulation. But when we are using the gonadotropin, the following should be considered. Number one, the cost of the intervention, as we know. Second, the expertise required for the use of the intervention and intensive ultrasound monitoring and a low dose step of gonadotropins to optimize the chance of monofollicular growth and minimize multiple pregnancies. Laparoscopic ovarian surgery. I also could be the second line of therapy in case of colon concentrate resistance and with there is no other infertility factors. But when we are using laparoscopic ovarian surgeries, the following should be considered. And the comparative cost of the intervention for ovulation induction, expertise required for the safety, and the both intraoperative and post-operative risks, which are higher in women who are obese or overweight. But please, do no harm, please, at all. As we know, the laparoscopic ovarian surgery can cause lower ovarian reserve and loss of ovarian function and perianexial adhesion. So please do no harm. Please do no harm. And you should know that FSH was superior to the laparoscopic ovarian surgeries for live birth rates, but we have a problem with FSH as it increases the amount of pregnancies. So it should be an informed, sure decision making can allow the choice of the second line of therapy, either laparoscopic ovarian surgery or gonadotropin, based on the patient's preferences and the pruritus. The IVF and the IVM. Actually, IVF should be offered in women with PCOS in case of failure of the first or second ovulation induction therapies. When elective single embryo transfer is used, multiple pregnancies can be minimized. IVF resulted in a higher live birth rate more than the IVF. Which protocol? Actually, the usage of the GnRH and Technos protocol is recommended. Why? It's enabling us to use the aggressive trigger for safety and the freezing of all embryos without compromising the cumulative live birth rate and actually to reduce the risk of ovarian hyperstimulation. Triggering the fact, actually, safety comes first. The agonist trigger decreasing the possibility of OHSS. But in 2018, ESHRE guidelines, the HCG is best used as the lowest dose to trigger the final oocyte maturation. The choice of FSH. Actually, there is insufficient evidence to recommend a particular type, urinary or recombinant FSH preparation. So the clinical choice of the gonadotropin should depend on the availability, convenience, and the costs. The exogenous LH. Exogenous recombinant LH treatment shouldn't be routinely used in combination with FSH. But clinical gonadotropin choice actually depends on the availability, convenience, and cost. Adjuvant metformin. Metformin actually reducing the estradiol level and the VEGF, it's called the vascular enteric risk factor. So it could be used in case of gene-rich agonist lung protocol to reduce the risk of developing of OHSS and miscarriages. When we are using metformin, the following could be considered. As we commence the metformin at the start of the gene-rich agonist treatment and gradually titrate the dosage of the metformin to minimize the side effects, and stopping the metformin therapy at the time of the pregnancy test or period, unless there is another proof for using the metformin therapy. The IVM. Actually, when you are using the IVM, there is no risk of ovarian hyperstimulation, but there is a risk for decreasing the live birth rate and the clinical pregnancy rate. But we can use the IVM in two cases. It should be offered in an option in one with a previous history of severe HSS, or or there is a risk of increased severity of HSS to be expected, provided that expertise in IVM techniques is allowed. Myostatin. Actually, it is a nutrient supplement that acts as a second messenger in insulin and FSH signaling, but still experimental therapy in women with PCOS and infertility. Anti-obesity agents. For predictive outcomes, it's still only in research settings to establish the efficacy and safety. To summarize session, if you have a case of PCOS, you should optimize the pre-conceptional health and lifestyle. Should followed by the first line medical treatment, which is letrozole. If there is ovulation detected, you can repeat cycles up to 6 cycles with a short decision making considering the age and the resources, then to IVF. If there is no ovulation, you can go to the second line, which is the gonadotropin with a strong ultrasound monitoring, or laparoscopic ovarian surgery, but believe you should know about the loss of ovarian function. It can damage the ovaries. If the ovulation detected, you can repeat cycles and actually the shared decision making considering age and resources, then go to IVF. If there is no ovulation detected, the third line medical treatment is the IVF. Thank you.